So thank you for this invitation to participate in the meeting here in Indonesia that's on the web. My name is Gὂran Olivecrona. I'm an interventional cardiology in Lund University Hospital in southern Sweden. And the topic of my presentation is an overview of complex lesions in PCI. And of course, we could make this a very, very long presentation, but I'm going to give you some viewpoints and tips and hints of what to do and how to develop it. So these are my disclosures. And I really have nothing in concern with this participation or this presentation. This is an overview where I live and work. This is southern Sweden, just across from Denmark. There's a bridge connecting the two countries. And in the middle of the picture is the hospital that I work at. So to start, what is a complex lesion? Well, complex lesions can be typed in many ways. You can call them A or B or C. And those are the typical sort of lesion subsets according to calcifications and thrombus and bifurcations, likewise termed similarly. But it's also, many patients have chronic total occlusions, and these can also be classified in the JCTO score according to their level of difficulty. Speaking about bifurcations, there's a similar classification there with a Medina type of bifurcation stenosis. It's also important to know about calcification, especially in post-CABG patients, which can, of course, make the procedures much more complex and difficult. And similarly, what is the patient risk? There are low-risk patients, high-risk patients. When you talk about bleeding risk, and for example, there's also about ejection fraction. Is that a risk? Age factor. There are lots of patient risks also involved. You can somehow see also that the impact of syntax score and the level or the extent of the coronary disease and what type of lesions that are involved. Also, you have to look at the availability of operator skills and the skills and the center experience. A complex procedure can be very, very complex for a younger operator who has not practiced for a long time, but it can be a moderately complex procedure for somebody who is a very skilled operator. What is the availability of equipment for complex procedures? In other words, if you don't have the equipment, even a moderately complex type of procedure can become even much more complex if there's a lack of equipment. And that's what I said in the next phrase, that a modestly complex procedure can be very complex if there's a lack of equipment or a lack of the operator skills, or you are in a center where the personnel are not really up to this. So developing your complex skills is that you generally start within your comfort zone when you're beginning your career as an interventional cardiologist. Then you have the possibility of entering the fear zone. That's where you find excuses or you would like to rationalize why you don't want to do something, or you can find a good excuse for it. And this is something that you need to improve on. And you can do this in the learning zone where you deal with the challenges and problems. And you, for something you can't do, you acquire the skills to perform it. And this way you can extend your comfort zone into the more complex procedures. And you continue to grow when you find a purpose, you set new goals. If there's something that you're not good at to do it, type of bifurcation, well, if you then set your mind to do that type of procedure in the next year, and then you can improve your skills and learn, and then set a new goal the next year. There are many modifiers and variables for PCI and their complexities, and this is just some of them, even though it covers many. It could be unprotected left main coronary disease, which is the variable, and the modifier is the location of the lesion and extent, calcification. In bifurcations or trifurcations, it's the Medina classification, it's the angles and the possibly the presence of calcification. In severe multivessel disease, it's the syntax score, that's the modifier, and the ability to perform the complete revascularizations. And then if you go further down there, there's the heavily calcified disease, which is the clinical variable, and the modifier is if you have the availability of rotoblader or shockwave type of balloons, is there any possibility of embolizations? And of course, when you look at total occlusions, it is the modifier is what is the likelihood of successful CTO procedure, which means that what are the operator skills, what's the availability of equipment. Further down, you have the impaired left ventricle, right ventricle, and that's the question: is there availability of devices to support you, such as Impella, ECMO, and so on. Speaking of that, then we look at the patients that have an even higher degree of complexity, and that is the complex patient with a higher risk. So then we're stepping into the territory that it's a complex lesions, but there's also a high risk involved. And this could be, for example, calcified left main type of procedure in a patient with a reduced ejection fraction. And you have to look upon the number of points here before, and you have to identify is the patient suitable. Is there an objective evaluation by a CHIP heart team? You have to plan the case, the treatment, and possibly additional testing. And then you do the actual performance of the CHIP PCI, which is the abbreviation for complex high risk indicated patients. And of course, you have the recovery and the aftercare and the step down. Make sure there's no bleedings, especially if you've used large bore devices such as ECMO or Impella to support you in the procedure. And so the planning and performance of these complex high-risk patients, after you identify patients, you have to sort of find patients that have severe obstructive coronary disease that are approachable by PCI. Is there a reasonable likelihood of functional improvement and survival? In other words, you don't want to do a CTO in a patient which has no myocardial viability in the territory supplied by the CTO. You have to make sure that it's a large enough ischemic burden or high risk presentation. And you would like to achieve as complete or near complete revascularization as possible. Technical considerations we talked about earlier, those are many. You can list these by the complex lesion type. I think this can be readily available on the internet or from published manuscripts, where you can see that, for example, unprotected left main, you have to have an objective assessment of lesion severity, complexity. You have to have, of course, availability of the tools, and you have to select the right technique for this. And this goes down to CTOs, vein graft disease, thrombotic lesions, and hemodynamically unstable patients, as well as bifurcations. And to show you a little bit about what I mean by this is a complex case. It's actually an older female. She's actually had angina for quite a while. She eventually ended up in our hospital with an N-STEMI, and she was turned down by the heart team for cabbage. So what do you do in this scenario? I think this patient has very limited if we don't do something for her. And this is what the images look like when they're moving, and it's a very, very heavily calcified stenosis at the distal part of the left main, encompassing both the LAD and the circumflex proximal arteries. So the challenge here was, having the equipment and how to approach this patient. So cabbage or PCI, well, the surgeons turned it down. What I would also think about is there a need for hemodynamic support? Like I said, operator experience and availability of equipment to deal with this scenario. So what do? Well, we decided to use a 7 French catheter. I think this is very useful when it comes to many bifurcations involving 2-stent type of procedures. And we discussed about this and decided this was definitely going to be a two-stent type procedure. We then faced the most immediate challenge, which was just safely wiring this lesion and then going for the LAD. And to do this, we also thought that we need to definitely do a rotablator, and we want to establish safe passage of a rotor wire into the LAD. We started with a Fielder XT wire and a Turnpike LP or small microcatheter, and we could get this down into the LAD. And after we have the wire in LAD, we could then fairly easily cross over with a Turnpike LP and switch this to a rotor wire. So first part of the game started, and then we started with rotablator, and it was actually quite challenged to cross this lesion. We started with a small 125 burr, and we actually ended up going up in increments 1.5 burr size, 1.75 burr size, and then 2.0 as debulking. So after this part, we then went on to the next step, which was the circumflex. This is just looking to see what the result was. Patient was actually quite stable hemodynamically. We thought about putting in an impella, but her peripheral arteries were not quite large enough, so this was not really an option for us. So next step was wiring the circumflex, which was quite easy after we debulked the left main. And after that, we decided to use a scoring balloon to the LAD and to the circumflex. And then we proceeded with 3.5 NC balloons to both arteries through the left main. Our favorite choice in my institution in scenarios such as this, with a distal left main Medina class 3 or 111, is to use DK crush. So this was then planned from the onset of the procedure. And this is when we put the stent into the circumflex from the left main, and we have a balloon that we're going to use for crushing the stent after placing it from the left main to the circumflex. So after the stent has been placed, I recommend to use a pot balloon, in other words, a 4.0 or 4.5 balloon in the left main, to sort of crush down the part of the stent sticking out in the left main, so that when you're rewiring the circumflex, you're not going to get into any problems by having the wire going around the wrong struts and enter the circumflex. After this is the first kissing balloon that is performed from the left main to both the circumflex and LAD. And then there's a stent placed in the LAD from the left main. And after stenting the left main to the LAD, use a proximal optimization technique balloon, pot balloon in the left main to further facilitate the passage of safe wire crossing into the circumflex, going through the right part of the stent. And this is what we do then often, and this is a little tip that try to enter the left main into the LAD with a loop on the wire. And then after that, also, I think it's useful to magnify the image. And after magnifying the image, go to a high pulse rate, where you can sort of see exactly where you want to go into the circumflex. And I think this is a quite useful technique. So high magnification, collimate the image, go to a high pulse rate just for the crossing. And after you've done with the crossing, you go back to your normal pulse rate. So this is not cine, this is just fluoro that we use this for. After passage here, it's a question of doing the second kiss. So this is kissing balloon again from the left main to the LAD into the circumflex, and then finishing with a final pot balloon. And then if you want to do a final second kissing balloon, this is your time to do it. Or sorry, this is the final pot balloon here. And then you end up with a result like this. After you achieve the result, you need a mandatory IVUS to be performed, and we did this in this patient and saw that the stents were well opposed. So this is then the final shot, and the patient recovered very nicely and did well. So on the other hand, the department wasn't quite happy. This is, quite a costly procedure. But at the same time, if you would have taken this patient to surgery, 85 years old, I think there would have been, very significant costs also involved. I think the costs are most likely somewhat lower, but it's clearly much more complex than a regular PCI procedure. But this is then, an alternative to CABG. So yes, there are going to be costs. So with that, I just want to go to a second case, which has a different scenario. This is a 64-year-old previously healthy male who has just suffered a cardiac arrest. He has profound cardiogenic shock following ROSC, brought into a local hospital. They've then connected him up with a noradrenaline and dobutamine. He's got a blood pressure of 60 millimeters mercury. His ECG shows left bundle branch block, and echo shows general hyperkinesia with an EF of 10%. And in this condition, he arrives to our hospital. This is what he looks like on his first angiographic image. And he's got a chronic occlusion of his LAD after his first diagonal. He's got a chronic total occlusion of his circumflex, follow the first marginal branch. And you can see collaterals also to a right coronary artery in this image. And if you look upon the right coronary artery, that's also chronically occluded. When you can see from this image, there's also some collaterals actually to the distal right that in turn gives collaterals to the LAD. So the question is what to do. CT of the right coronary artery, LAD in the circumflex, and he's in profound cardiogenic shock. So normally I'd like to bring this patient up to surgery. And our surgeons, of course, don't want to operate on these patients if they are on T2Y12 inhibitors. He's only received intravenous aspirin and heparin. And I contacted the surgeon, but they just started operating on an aortic dissection. So this was not available at this time. So we decided then to proceed to PCI. But prior to proceeding to PCI, we placed an Impella, and the patient stabilized somewhat in his blood pressure. And then we decided to at least attempt to open the right coronary artery. And this is when the operator skills that you acquired from doing complex lesions and CTOs can help you, even in these acute emergency patients. But if you have the skill sets here, it will help you in your regular ordinary PCI. So there was no planning that I would have this patient when I was on call. And we still decided to proceed. We did this then with a fine cross microcatheter and started with a Fielder XTA. And the next step is to go then to wire escalation. When the Fielder XTA didn't work, we went to an Ultimate 3 and then to a Gaia 3 wire. And we were somewhat lucky that the Gaia wire went in and could actually then proceed to pass the chronic occlusion into the distal right. So the surgeons are unavailable for next many hours, and the question of what to do then. And I decided then to continue to do PCI, but perhaps not putting in stents, only using POBA. But discovered also in the process that these stenoses in the right coronary artery were rock hard. And we had to go to quite high pressures with NC balloons to break them. But we established good coronary distal flow. just with POBA. And following this, the patient actually became very stable. His blood pressure didn't normalize quite, but he had a blood pressure of 110, 115. And we decided then that he still will do better as a surgical candidate. And they could probably operate on him later on that evening or the next day, as long as we didn't give the patient any P2Y12 inhibitors. So we left him only on heparin, IV, and aspirin, of course, that he receives. And no stent was placed. Next day, the patient underwent CABG with Lima to the LAD off pump with the Impella still in place. And the day after that, the patient came back to our lab. And this is what it looks like when he comes back. And it's a very calcified right coronary artery. Impella is still in place. We continued with a rotablator to the right coronary artery and could successfully do that, and then proceeded to stent most of the right coronary artery. And we could find then a final result that looks like this. So the patient is now revascularized to the LAD and to the right coronary artery. So what happens afterwards? The Impella is withdrawn 2 days after the PCI. Patient recovered well, discharged after 10 days. EF at follow-up was 40%, and he's planned for to later undergo a CTO PCI of the circumflex artery. So I think that if we're getting to the end of the presentation, it's very much a question of become comfortable being uncomfortable. So in my conclusions, I think that we can say that complex PCI is very much multifaceted. It's a question of lesion complexity, lesion risk, patient risk, operator experience, availability of equipment and resources at the PCI center to match then the operator experience. And it's important to continue to grow and further the horizons and learn. And this is the way to move forward to perform the complex PCIs. And with that, I thank you for your attention.